Hey, good evening, everyone, and welcome to our webinar event this evening. My name is Jane Miller from Central and Eastern Sydney Primary Health Network. Tonight, our session is about delivering healthcare to people experiencing homelessness. To begin tonight's session, Central and Eastern Sydney PHN acknowledges the Aboriginal and Torres Strait Islander peoples of this nation. We acknowledge the traditional custodians and sovereign people of the lands across which we work. We recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. We also welcome any Aboriginal people joining us tonight. Just have a few extra messages from Central and Eastern Sydney PHN before we get into tonight's webinar. So the first thing to mention is the IARDST, or the Initial Assessment and Referral Decision Support Tool. So this is a new online tool that matches patients with mental health care. At the moment, we're running free training for allied mental health professionals, practice nurses, GPs, and GP registrars. The second thing I'd like to mention are some new healthy ageing hubs. These hubs provide practical service support and guidance related to healthy ageing. They're not a case management or a clinical service, but rather they provide support and referral information for older people in our region. For example, they could provide extra assistance with the My Aged Care system or connect to older people with social activities in their region. We have two hubs that have been set up. One is at the Gymea Community Aid and Information Service, so that's in the Sutherland Shire, and we have a second hub at the Newtown Neighbourhood Centre in the Inner West. The services can accept GP referrals or self-referrals. The last new service I'd like to mention is the Care Finder service, and this is a new Commonwealth funded program for our region and across the country. The Care Finder service will provide support for connecting vulnerable older people, including those experiencing or at risk of homelessness, with aged care and other support services. We have established a network of Care Finder organisations across our region, and there will be a central intake which will be coordinated by Sydney LHD. There's more information available on the Cessford website, the My Aged Care website, and information is being added to HealthPathways as this is a very new service. And just to remind everyone, as always, we do have a lot of upcoming events, which are listed there on the screen. You can find more information on the Cessford website or in our e-newsletters. So I would now like to hand over to Amanda Webster, who is the Manager of Priority Populations at South Eastern Sydney Local Health District. Thanks, Amanda.
Thanks, Jane. It gives me great pleasure to welcome and introduce our presenters for tonight's session. If we could all turn our cameras on, that'd be fabulous. Joining us are Dr. Lucy Cooper, a GP from the Matthew Talbot Primary Healthcare Clinic, Dr. Amandeep Hansra, a GP who also works at Matthew Talbot at Bondi Doctors and is a digital health advisor to the Australian Digital Health Agency, Dr. Karen Chung, a GP clinical editor with the CES-led HealthPathways, Tali Starr, consultant advocate specialising in trauma, domestic and family violence, homelessness and disability, Paul Clenahan, Program Director, Homelessness and Rough Sleepers at Sydney Local Health District, and Jeanette Ball, Women's Health Nurse in Priority Populations at South East Sydney Local Health District. Tonight, we'll give you an overview of homelessness, trauma-informed care, and a framework for working with people experiencing homelessness in primary care. 2 case studies will be presented, and there will be information on health pathways relevant to homelessness. Following the case studies, there'll be a panel discussion and an opportunity to ask questions. In Australia, homelessness is defined as a problem that goes beyond rooflessness and a lack of access to safe shelter. The experience of homelessness includes vulnerable people living in refuges, crisis accommodation, or in temporary housing. On census night 2016, there were over 13,000 people experiencing homelessness across the Central and Eastern Sydney PHN. And of these people, 5% were sleeping rough, 10% were residing in crisis or supported accommodation, and almost 4,500 people were living in boarding houses. Broadly, we use 3 categories to capture the diversity of experiences of homelessness. Most people are familiar with primary homelessness, the visible form of homelessness, such as rough sleeping. But people residing in refuges, hostels, or staying temporarily with friends, and people living in boarding houses with no security of tenure, are also defined as experiencing homelessness. These types of living arrangements are unstable and are likely to impact a person's ability to establish a relationship and sustain that relationship with a GP. So who experiences homelessness? There are a number of drivers of homelessness, and domestic violence is one of the leading causes of homelessness in Australia today. There are also populations who are at greater risk. And according to census data, older women, children and young people, and Aboriginal and Torres Strait Islander people are the more at risk of experiencing homelessness in Australia right now. So a key issue to consider is asking about someone's living situation. Some people may not identify that they're experiencing homelessness. This might be because it is new for them or because they've been staying in the same place for a long time. What's important is that we identify and think about how where a person is staying might impact on how they can engage with healthcare, and how this might create challenges for things like maintaining appointments, accessing medication, and following through with recommendations and lifestyle changes. I'm now going to hand over to Tali, who is going to talk to us more about trauma.
Thanks very much, Amanda. This is such an important topic to think about, and how trauma actually impacts homelessness. I think the difficulty with people who've experienced trauma is their behaviour is often misunderstood. And this trauma can show in all sorts of different ways. And it can seem as a disconnection, and it can seem as like it's not, they're not actually wanting to be part of what we're doing. Let's look at what trauma is first and foremost. It's a single incident or it's multiple incidents. It basically can have a long-lasting impact on people. When we talk about it in medical circles, we often talk about it devoid of any kind of emotional and psychological impact. So we might say something like a blunt instrument trauma. To truly understand trauma, we need to have a holistic view of it, and we need to understand the intersectionalities that go on at the same time. So if a person is experiencing homelessness, they might also have a disability, or they might be from a non-English speaking background, or they might be from an LGBTQA+ group. They could also be from an Aboriginal background. So we need to take all of those things into account. They might present for health, but what's actually happening for them is that they have an animal who is sick, or their teeth are a problem. So we need to listen to what their concerns are. The other problem with trauma is that the systems that they're engaging with are often traumatic for them, or have caused abuse for them as well. So we're asking them to go into places that aren't safe for them. When we set up hospitals, it was post-war to triage people to move them through, and this hasn't evolved, and we haven't done trauma-informed training and embedded it into our systems. So we need to keep that in mind when we ask people to move into those places for assistance. And the other problem is that people need to feel safe. And so we can be that safe conduit for people. We can help them in an inflexible system to feel safe. So what I thought I'd do is create an acronym for you around the word trauma to help us to really think about, well, how can we be engaging with people in a safe way? So T is for trust. Trust is earned, it's not demanded. And when you experience trauma, you don't really know who you can trust. You're in a heightened state of arousal, and you go into a fight, flight, freeze, or fawn mode. In these moments, we need compassion, and there needs to be someone who's calm. We need to create a safe place for people to be. If we trust the person that they know themselves and they know what is going on for them, then we're going to get a better result as well. Because when we refuse to hear what's happening for them, they will refuse to take our assistance. We need to listen and hear what people are saying and understand the reasons could be compounding reasons why in this moment they're saying no. Because behaviour is an indicator that something is not right. And it's in the understanding of what is not right that we'll actually achieve what we need to. We also need to be consistent to build trust. Our behaviour needs to be the same each time we see them. And if for some reason we can't behave in that same way, something has happened, then let's let them know. Let's tell them in an appropriate way. I had a doctor that had something happen once, and I said to him, "You're not the same as you were last time." And he said, "You're right. Unfortunately, I had somebody pass away yesterday." And that made all the difference. He didn't need to say much, but it helped to build that trust, because trust is about relationship, and their relationships have been broken. Then we move to R for respect. And respect is vital. And again, like trust, we cannot demand respect. And we might have a whole lot of letters behind our name, but when we demand respect, we will lose that person and lose their trust. We need to know ourselves and what's happening for us and the way we respond to things, so that we can be in that moment with that person, showing them the trust and respect that they need. Trauma is a thing that can take over a person's body at times, but when we work with them and we show respect, we help them to feel safe. And being safe is vitally the most important thing that can happen. People who've been through homelessness and trauma have the most amazing resilience you can ever come across. I work on a high needs panel, and I see 30 years of homelessness. The person is still going, the person is still finding ways to move through this. We have to understand that trauma affects a person's brain in a way that they can't really have full control of. When they go into that fight, flight, or freeze mode, their frontal cortex stops working and they can't process the things that are happening for them. So we need to not infantilize them. We need to treat them like they are equal human beings. And when we do that, we draw on their strength and we build the respect with them. And in the same way that respect and trust work together, we need to understand that this person has lived in this body their whole life. And just because we've got letters behind our name does not mean we know what we're doing in terms of their body and their experience. So A is for authenticity and really being who we are and knowing who we are. What is unique about us? If I was to ask you that question, would you know what that was? Because that's the thing that you bring that nobody else brings. And when we're authentic and we rest in the place of truth about who we are and how we behave and what we do, then the other person will respond to us in a calmer way. If they pick that we are not being authentic, they will see through it straight away. They are scanning every situation to see who is safe, what is safe. And if we remember that the people that were supposed to be safe are the ones that have perpetrated violence against them or caused their trauma, then we will understand how important that authenticity is. We don't have to pretend to know all the answers. We don't have to be who we're not. We just have to be willing to listen and be in that space with people. We need to come from that genuine, engaging place. If we don't know something, then look it up or tell them. You'll investigate. Take what they're saying on board, because what they're saying will really make a difference to how you work together. Let them know that you see them, you hear them, and you're with them. The other thing I wanted us to look at is unusual things, which is you. So looking out for what seems out of the ordinary. And I want us to really think about it in terms of violence is not an ordinary, normal, usual response. So if someone is behaving out of that place, that is not usual. If we're working with people with domestic and family violence, we need to be looking at what is the unusual behaviour of the perpetrator? What are they doing? How are they behaving? How are they making the person who is their partner feel? because this is what we often miss, and we focus on the victim survivor rather than the perpetrator. And if we are working with perpetrators, we need to be careful about the behavior that they're showing. Look at what's happening for them. What is unusual about what they're doing? And think about how we can manage that unusual behavior so that we're safe and they're safe. When we're looking at victims as well, we need to think about things like, are people who've been through trauma, are they withdrawing? Are they quiet? Are they reserved? Have they disappeared? Are they still with us? Those kind of things are really vital to us observing what is going on. So look for what is unusual in the situations and the behaviours that we've seen, because behaviour is an indicator of so much. We need to observe body language and we need to observe facial expressions, not just the words that people are using. And that leaves me to M for mutuality, because if we are working with our eyes open, we will be understanding the situation. And when we understand the situation, we can work together. Mutuality is the most important thing. What we often do is we come into a situation and think, this is what I need to do to organise this situation, rather than what does this person need? Mutuality is about being person-centred. It's about knowing and understanding what is going on for the person. What is their priority? Is their animal sick? Is that what is the most important? But making sure we focus on them and what is happening for them. Look for their cues. Look for what is going on and work together. And if you have to report something, then know and understand what is happening and why that needs to happen, and work with the person to do that. Do not take the power out of the person's hand unless there is a safety issue. And that brings me to my final point of action, because action has to be action with consent. We cannot take that power away from people. We cannot make decisions for them. If we do that, we are rescuing them and we are disempowering them. So we need to ensure that what we are doing is actually with complete consent. And we need to understand that trauma has a big impact on people. And we need to understand that healing will come and recovery will come. And we can be part of that healing and recovery. We just need to understand that when we build trust, respect, authenticity, look out for unusual behaviour, work in a mutual way, and act with the person's consent, then we are rebuilding their situation that they've been through, breaking down the barriers of trauma. How a person is responded to when the trauma occurs determines what their trajectory is. Trauma hurts a person's soul. Compassion and kindness helps repair the wound. Thank you. I'm going to hand over to Paul.
Thank you, Tali. That was brilliant. And I must emphasise that trauma-informed care, and that trauma acronym that Tali presented is really the foundation of everything that we do with vulnerable populations. And I hope when we get to the questions part of this presentation that there's a few questions of trauma. So thanks again, Talia. I'm going to talk about working with patients who experience homelessness, and we've just developed a framework for primary care. We could go to the next slide. The framework is 5 or 6 key points, and I'm going to go through each of these points, but they're engagement, assessment, treatment, referral, communicate, and plan. So the first stage is engagement, and I must say this is one of the toughest stages when working with people. And again, some of the points that Talia raised about mutuality and authenticity are certainly 2 aspects of engagement, but the 3 dot points that we've got here is that people experiencing or at risk of homelessness may have had poor experiences of care in the past. It's almost guaranteed that they've had some poor experiences of care in the past. We should consider how these experiences might shape an interaction in a primary care or other health setting. And we need to collaborate to identify the key priority or need for the person during the appointment. That's a key issue, and it's about looking at what the person actually wants. So the second stage is assessment. What is the person's priority as they present? What is it that they want? What is appropriate to explore in the first appointment? What else needs to be explored in later appointments? And who else is involved in the person's life? Try and find out what makes what gives that person meaningful, what makes life meaningful for them, and what does each day look like for them. So what happens after they leave the GP practice? What will their day look like? What did their day look like before they arrived in the GP practice? The next stage is hopefully getting to treatment and looking at the presenting issues. And then what's brilliant about GP practice is often considering appropriate opportunistic interventions. I know when I go to see my GP, I might go about the knee injury that I got playing football, but before I know it, I'm having pathology tests, vaccinations, and other questions as well. So use the opportunity when you see a person who's experiencing homelessness to look at the blood tests, vaccinations, screen for Hep C and bloodborne viruses. Referral is really extremely important. For many people who experience homelessness, it's a one-off appointment and perhaps they don't come back. So with consent, we want you to refer to other agencies, and consent may not be necessary if the issue is life-threatening. Look at HealthPathways, and there'll be a few slides on HealthPathways later on to look for some guidance. And look at what specialist health is required. Mental health is often the issue that's most considered, but think of some of the other issues that might make a meaningful difference in the person's life and may be achievable. And oral health is certainly one of those pathways, and Sydney Dental Hospital is an example of a good health pathway for people who are experiencing homelessness. For many people who are rough sleeping, I would say over 90% of people who are rough sleeping in Sydney, other services are very, very much involved in that person's life. So there's very few anonymous people who are rough sleeping at this point in time. So try and communicate with those services, find out who those services are, and try and work with the person to see whether you can liaise with those services. Think about the plan then, and think about the barriers to follow up. Some of the barriers that we experience, we can easily overcome, but a person may not be able to navigate the health system quite as well as we do. Transport, going to and from appointments, getting letters, etc., are sometimes difficult. How can you work with the person to address or mitigate these? And that goes back a little bit to the last point about communicating with the other agencies that are involved in that person's life. And so that's the 6 stages, all presented with some content there. In the case studies that we're going to present now, we do sort of combine refer and communicate together. And at this point, I'm now going to hand over to Dr. Lucy Cooper, who works at the wonderful Matthew Talbot Primary Health Care Clinic. And Dr. Cooper will be presenting a case study. And I must add that the case studies are composite case studies. So although David will be the person that Dr. Cooper will be presenting, David is actually a mixture of a couple of people, and that's to hide identity as well. So Over to you, Dr. Cooper.
Thanks very much, Paul. I'd like initially, if I may, to spend a few minutes just talking about Matthew Talbot Hostel and its history, and then I'll move on to David, who is gives a fairly typical story that we might hear and reflects the difficulty that people experiencing homelessness might have engaging with the healthcare system. So in 1938, St Vincent de Paul established the Matthew Talbot Hostel to offer shelter and support for men experiencing homelessness in inner city Sydney. It opened with 11 beds and served 100 meals a day. Next slide, please, Jane. When I first visited the hostel back in the 80s as a medical student, it was a very busy place. At that stage, it was accommodating 550 men each night. As you can see in the top right-hand side of the slide there, it was in large dormitory style accommodation with double bunks, and each man had a little open wire basket to put their belongings. The hostel was serving hundreds of meals every day, and here's a photo on the left-hand side of the dining room. The clinic itself was a very busy place. There was a 25-bed sick bay, and they also had a place called the drunk tank, and here is a picture of it on the lower right-hand side of the screen, where 80 men could be looked after by the nurses and watched while they recovered. Next slide, please, Jane. Of course, the hostel is a lot different these days. The living conditions are a lot more dignified, and we accommodate 98 men in single rooms, which offers greater personal space and privacy and security. The gentleman on the left there with the stethoscope is Professor Ian Webster, who was essentially set up the clinic back in the mid-1970s as a nurse-led clinic, which continues to be today. So we have 2 experienced registered nurses who are on duty 365 days of the year to care for the health needs of the men. We have a 5-bed sick bay. The nurses also facilitate visiting specialist clinics in general practice and psychiatry, as well as optometry, podiatry, and visiting outreach clinics from St Vincent's Hospital in diabetes and heart failure. On the right of the screen, the other gentleman with the stethoscope is one of the many visitors to the hostel, and it's why it's such a joyful place to work. Men like this gentleman have enduring relationships with the staff and come back to the hostel over decades. The slides previously were Ian Webster's slides, and I thank him for those. Next slide, please, Jane. So that brings me to the case history of David, who is a 62-year-old man who presented to the clinic with profuse left-sided epistaxis of 2 hours duration. David denied any intercurrent illness or past hospitalisation. He was on no medication. He didn't drink alcohol. He wasn't using illicit drugs. He denied any problem gambling. David was a past smoker, having quit 10 years earlier. He didn't report any significant family history of illness. David said he was sleeping in the open around the Sydney foreshores and had been doing so for the past 3 years. He was previously employed as an engineer in a company based in Adelaide. David's Medicare card had expired and he had not sought medical attention for about 10 years. He had no income and survived on food from charities. He washed his clothes and used internet services and other services at the homeless hostel and other homeless services around Sydney. David spent much of his time each day in the State Library, and he didn't nominate any next of kin. Next slide, please, Jane. So I'd not met David before. He's a lean Caucasian man who looked older than his stated age. He was dressed in neat casual attire, which was covered in blood. He engaged in an anxious but stoic manner, and he had sparse but terse conversation with poor eye contact, although he was cooperative. He had profuse bleeding from his left nostril. His pulse was 124. His blood pressure was very high at 245 on 130, and his oxygen saturation was good. On inquiry, he admitted to 20 minutes of retrosternal chest pain, which was aching in quality with no radiation. He had no nausea or vomiting, but was sweating profusely and looked really unwell. So we placed him on a plinth. One of the nurses called 000, and then we all spent much time trying to stop the bleeding in his nostril, which was successful with a nice strong pack. The ECG showed tachycardia and ST depression in the anterior chest leads. And all this time, David was kept informed of what was going on and provided with reassurance. While I was waiting anxiously for the ambulance to arrive, I called my trusty go-to cardiology friend, who suggested that I give him 5 milligrams of amlodipine, but nothing else. After David was thankfully picked up by the ambulance and taken to ED, the staff and I debriefed over a cup of tea. Next slide, please, Jane. 2 days later, I received a call from the cardiology registrar to let me know that David had had an NSTEMI and required surgery, but had declined treatment. And in fact, he'd just discharged himself against medical advice and he hadn't taken any of his medication with him. The registrar said he was deemed to be at very high risk of sudden cardiac death. Next slide, please, Jane. 2 days after that, David was cited having lunch in the dining room, and staff suggested he might like to wander up to the clinic. The nurses built a rapport with David and invited him to stay overnight in the sick bay. David remained unwell, but agreed that he would like to take his discharge medications, which were organised from the hospital. He declined to see me, the GP, and it was noted that his Medicare had been updated during his hospital admission. Next slide, please, Jane. 2 weeks later, I managed to catch up with David opportunistically while he was in sick bay. He told me that he was very shaken by the diagnosis of widespread coronary artery disease. He said he was very frightened of dying while he was in surgery, and he was concerned about the post-op pain that might be associated with the opening of his chest wall, which he told me was done with a bandsaw. He didn't enjoy the hospital environment and he left. I noticed that his MOCA during the hospital admission was 23 out of 30, and that his CT brain showed widespread microvascular ischemic changes. So David and I had a long discussion where we frankly discussed the risks both of having the operation and not having the operation. We discussed modern post-op analgesia and also his recovery options, which included coming back to stay with us in sick bay. We discussed the fact that we could help him with follow-up appointments and with his ongoing healthcare if that's what he would like. It was coming up for Christmas, and David decided that he would like to have the surgery, and urgent readmission was arranged, and he went back up to the hospital and was then discharged post-operatively back to us to stay in sick bay. Next slide, please, Jane. David remained in sick bay for 2 months after his coronary artery bypass grafting, and in that time we had the opportunity for ongoing engagement. David's blood pressure remained very difficult to control. His surgical sites were slow to heal over months, and in fact he sustained 2 wound dehiscences of his graft sites, which required antibiotics. We had the opportunity to take bloods for David, and they were all pretty good, apart from a low vitamin D, which we added to the other medications in his Webster pack. I wondered at that stage whether perhaps he was also low on vitamin C. As you would know, the free food available is often high in carbohydrate and low in fruit and vegetable. So the nurses arranged for 2 oranges to be given to David each day, which he enjoyed, and I was really amazed that very quickly his wounds healed. The nurses offered David immunisation, which he accepted, and I had the opportunity to get to know David's history a little bit better, although I couldn't do a full mental state examination. He, as you know from hospital, his MOCA was 23 out of 30, which is consistent with mild cognitive impairment. David was evasive around his employment history. He denied any forensic history. He told me that he was divorced with 2 adult children with whom he maintained email contact. He told me that his children were unaware of his current living circumstances. David mentioned that he'd fought in the Vietnam War and was deployed in the sniper division. When conversation turned to the possible emotional sequelae from such a confronting environment, David told me that he was just doing his job and that was what was required of him, and he didn't really believe in things like PTSD. He told me that he hadn't kept up with any veterans and he had nothing to do with the DVA. Although he did say that he had invested his substantial financial assets with Legacy House, which were in trust, which were kept in trust for his children when they turned 30. So David acknowledged that he had an unusual lifestyle choice and he appreciated our concern for his well-being. He said he valued his freedom and self-sufficiency. He told me that he had no use for money and that in the past he'd worked for extended periods on farms for food and board. So he appreciated our concern, particularly as he aged, but he told me that he was doing fine for the moment. So clinic staff helped and arranged his cardiothoracic and ongoing cardiology follow-up. David declined referral to Centrelink or for a disability support pension or indeed for community housing. David also declined a psychiatric referral. So we discharged David back to rough sleeping, which is what he wanted. He continues to collect his medication every day from the clinic nurses at Matt Talbot. Next slide, please, Jane. So David's experience is quite typical of somebody who has difficulty engaging with the health system. I think, as Tully mentioned so eloquently, there are lots and lots of different reasons for that. I don't know why David chose to live off grid. I wondered whether he had some sort of personality structures that perhaps had become more coarse and concrete with his kind of progressive cognitive impairment, which was secondary to his uncontrolled hypertension. I also wondered and didn't have the opportunity to explore whether he had symptoms of PTSD. But it does underline the importance of the therapeutic alliance and also the importance of a team-based approach. So there was always, we tried to maintain an environment of welcome and acceptance, of kindness, a focus on stability and safety, and also the respect the dignity of his choices. So whilst David's outcome was good, I admit that not everybody's outcome is as successful as his. Thanks very much, Paul.
Thank you, Dr. Cooper. And I think that illustrated some of the complexities of caring, treating, assessing someone who experiences homelessness. Just a reminder to the audience that there is a questions and answers box available, and we do look forward to seeing some of your questions later on in the session. I'd now like to introduce Dr. Amandeep Hansra, who's a GP at also the wonderful Matthew Talbot Primary Healthcare Clinic, and also works at Bondi Doctors, and is a digital health advisor to the Australian Digital Health Agency. And over to you, Dr. Hansra.
Thanks so much, Paul, and thank you for having me here today. It was great to hear from some great experts in this space. So my experience really is drawing on the experience that I did have when I was working with Lucy at Matthew Talbot Hostel, but I also did a lot of work in the Indigenous space at an Aboriginal medical centre over the years, and saw lots of patients experiencing and at risk of homelessness in that environment as well. So it's important to remember you don't have to specifically be at a clinic that just caters for patients at risk of homelessness, that it presents to you in everyday clinical settings, no matter what part of the country or what demographic you're working with. So just wanted to flag that. We are going to now move on to another case study. So this is Kira. So just a bit of a contrast to our previous case study. This is obviously a younger female, so Kira is 23 years old. She's presented to our clinic today reporting dysuria and increased urgency for the last 24 hours. So Kira is somebody that has a relatively insignificant sort of medical history. She's got a bit of childhood asthma. She's had a fractured clavicle. She doesn't take any regular medications. She vapes, not a big drug user, but has had a binge pattern of drinking alcohol. From her gynecological obstetric history, Kira has had a termination at age 17 and had normal periods other than that, menarche at 12 years of age, and has had normal sort of cycles with normal bleeding. Interestingly, in a sexual history, she has had chlamydia before 3 years ago, which certainly does, worry us a little bit when she's presenting with these symptoms. You're uncertain of, we were uncertain of her vaccination status, so did not engage with her regularly at the clinic, so did not know that she had HPV, or whether she had or she hadn't. She has also had a history of sexual assault at the age of 14 and has had inconsistent use of the oral contraceptive pill or barrier contraception, and it doesn't look like she's been offered or discussed or tried any other forms of contraception. I might just move on to the next slide. Thank you. So as with a lot of patients, it's always important to do a mental health history as well. And Kira has had a history of self-harm, has experienced some cutting to her upper thighs, no suicide attempts that are known of, but has got the self-harm history and no sort of formal diagnosis but has been seen by mental health services for the self-harm and potentially anxiety and depression. And that's also been compounded by the sexual assault that she had when she was a teenager, for which she received some counselling. Her family history has been quite complex. She's been placed in and out of home care, numerous foster placements between the ages of 13 and 16. Her birth mother is deceased from a drug overdose, and she's not had contact with her birth father and sporadic contact with the rest of the members of her family. You don't know any other family history because we don't have access to that. And her social history, she's currently unemployed, has been couch surfing in share houses with acquaintances she's met through work. And this is not an uncommon sort of scenario where you do have people relying on sort of friends and random people they meet to have somewhere to sleep. So she's never really sure how long she can stay, how welcome she is, at what point she'll need to leave. And she's had a history of physical and sexual abuse whilst in different foster placements. We'll just move on to the next slide. So as we mentioned earlier, it's so important to build trust. As you can see, a lot of the history taking that you're going to need to do in this environment are very sensitive topics. So obviously getting her to open up about her past sexual history, that she's had chlamydia, that she's had a sexual assault, her mental health history. These are things that are not easily shared, if the trust isn't built. So engaging is really important, and discussing privacy and confidentiality early in the consult, just to ensure that they understand that you're obligated to keep this information obviously private unless she's at risk to herself. So the next sort of step is really, once you've got that engagement and you've sort of worked out what her support systems are, is to really start the assessment. And obviously first thing most of us would think of is she got a UTI, and you would obviously investigate and look for any signs of that through a dipstick. You can send off for urine MCS, but it's also important to remember that follow-up can sometimes be challenging. So to try to do as much as you can with office-based tests is quite important. Obviously in this scenario, we want to offer STD screening, and you don't have any history of a cervical screen test, so we want to do that as well. Pregnancy is incredibly important in this scenario, so she's obviously at high risk, and you've got no sort of firm use of contraception history as well. And this is a situation where DV screening is critical, and this is something that doesn't just happen once. It happens every time you see somebody for whatever they might present with. If they're at high risk, there's someone that you should do screening regularly at each assessment. And again, building that trust up before you start asking those questions. And then we go on to treat, Kira. So prescribe antibiotics. And again, in a situation where you're unsure about follow-up, really important to make sure that treatment is provided, making the assumption that you may not see her for follow-up for results of the urine MCS. So on a sort of presumptive basis, choosing your antibiotics and treating her and counselling her regarding the STD screening. Also important while you have her in front of you to discuss contraception options, even if they say, look, I'm not active at the moment. Again, if you don't get that chance to get her back, that you have offered her things that work with her lifestyle. So if she's not somebody that can take a pill every day, making sure that she is given other options of longer acting contraceptive choices, and that that is explored with her in this appointment that you have her right in front of you. Obviously it's an opportunity for education and support around vaping and the drinking. So any opportunity you get for alcohol and drug screening and advice is again taken regardless of what she's presenting with. And then the most important thing obviously is going to be that you refer her for the things that she needs support for. And so social support is critical. And this is why it was really great at some of the settings that I was in both the Aboriginal Medical Service and also at Matthew Talbot, that we did have social worker support that can help around the accommodation and the homelessness issue. So you can focus on the clinical issues, but understand how those are going to impact her compliance and treatment options. Also really important to explore mental health services that she may need, and referrals. Maybe that, she doesn't easily find it easy to go and see a psychologist. We do have the options of mental health care plans, but again, trying to get some of those people to follow through on regular services can be challenging, but making sure she's got access to all the services that she needs, referral into things like Beyond Blue, Lifeline, 1-800-RESPECT or domestic violence lines, New South Wales is a sexual assault helpline, lots of services that are available in the community. Also discussing family planning centre options for her, sexual health clinics for future support. So she may not want to come back to a GP clinic, but is happy to drop into a sexual health clinic for a regular testing, and obviously offering the sexual assault and other psychosocial support. And then the really important part is having a plan of action at the end of this consultation. So we want to make sure that we get her back to talk about STI screening test results, and make sure that if she's got any ongoing symptoms, also get the results of the urine MCS and follow up her cervical screening test results, because she may need ongoing treatment or follow up for that. It's important to give people choice about how they want to follow up. So giving them the options. Do they want to have a phone call? Do they want to come back in, make the appointment there and then, and something that fits in with their schedule and where they're going to be? The least amount of friction that you put in place for people to come back for follow-up is really important. So thinking about where she may be located, transport options, and making sure that you have a way of contacting her. And sometimes it might mean having to get a few different phone numbers, or, having other people that that might be able to get in touch with her if you needed to urgently let her know that a result had come back and that you wanted to discuss it. So confirmation of contact details, very important. We'll just move on to the next slide. Thank you. So you get the results back. Unfortunately, her cervical screening test results indicate that she does have HPV 16. She needs referral for a colposcopy as per the CST guidelines. Her STD screening has come back negative. But unfortunately, she hasn't returned for a follow-up appointment, and the mobile number she's given is disconnected, and that we haven't got any other way of contacting her. So unfortunately, she's lost a follow-up, and we move on to the next slide. Unfortunately, again, we do get to see her 2 years later, presenting at 25 years of age. We have no information in between, but she's now presenting with bleeding after sexual intercourse. She's living at a women's refuge now. She's had an experience of serious physical assault by a recent partner, and she does have an AVO out in this partner. Again, we go through the same process of engaging, discussing, again, privacy, confidentiality, even more critical when she's feeling quite vulnerable and threatened, and she's currently in a refuge, to make sure that, she doesn't feel like any of this can lead to disclosure of where she is or that she's engaging with the health system. Also discussing what kind of support system she has at the moment, and also making sure that you've got those contact details with her consent of how you might get in touch with her, considering that you've had this 2-year gap in her treatment journey. In terms of assessment, so we check the National Cancer Screening Register, which has shown us that she has had a previous result, presence of HPV. We do the DV screen again, even if we know that she's had this serious physical assault. It's important to just make sure that you've got all of the latest detail, that she's not at risk, that she has, supports in place that she needs. And then the next step obviously is to treat her. So again, looking at whether she needs to have another STD screen, and consider whether you have a clinician collected sample, or whether, and we'll talk a little bit about HPV self-collection of CSTs. And now she needs a referral to the colposcopy clinic, as well as providing the DV support and mental health support and any other psychosocial support. And obviously it can be quite threatening and overwhelming when you have disclosed that she's got a medical issue that needs follow-up. So making sure she's got counselling in place to help her deal with that kind of news. And the plan is to have the colposcopy follow-up. And again, really important that everything is put in place to make sure that she can get to that appointment. And it may be assisting her with transport, making sure it's put on at a time that is suitable for her, and ensuring that, issues around her past history of sexual assault is something that's recognised and acknowledged, particularly when she's going to have a colposcopy, because often, those kinds of procedures can be very anxiety provoking for somebody with a history like that. And obviously continuing to provide primary healthcare support for Kira. So we'll just move on to the next slide, thanks. And Paul, I might hand back to you, thank you.
Thank you very much, Dr. Hansra. And if I could invite all the panel to put their cameras on. Thank you. And if I could also invite the wider audience to give us some questions that you'd like to discuss or raise. These might be based on the case studies, or might be based on Tally's presentation on trauma, or could be of any issue about your experiences treating people who have experiences of homelessness. So we will give that a few minutes, and I might start off the conversation whilst people think about some questions, and I might ask Dr. Hansra and Dr. Cooper to comment on the challenges and rewards of their work. Issues like continuity of care, the complex diagnostic issues, and management of maybe drug-seeking behaviour as well. Dr. Cooper or Dr. Hansra, would you like to open up some discussion on that?
Sure, thanks, Paul. I've been working at the hostel for 20 years now, and I look back and I wonder, what have I done? And I think really most of it has been engagement. So that's a challenge, and it's also a pleasure. And I guess you get better at it the more you think about what the other person might be experiencing. Other challenges for me have been the complexity of the diagnosis and multimorbidity, but that's also really interesting, and I enjoy that. another big thing I've found is the fact that when the person goes into hospital, it often ends up as a great big black hole. You don't get the discharge summary, they don't come out with medication, and the communication breaks down. So you can spend a lot of time trying to chase up exactly what's happened to them. So I guess that comes into the continuity of care. Certainly there are rewards, and yeah, I find it just a joyful place to work. I really love working with the interesting people, as I think Tully mentioned, just very resilient people with amazing stories of life, courageous. It's just incredible and inspiring. I also really love working closely with the nurses and also with my non-GP specialist colleagues with whom I have a close relationship, and often it ends up being that we manage these complex patients who might not be able to get to appointments at the hospital or elsewhere in a kind of shared care arrangement. So I find that really fulfilling. So yeah, interesting medicine, fantastic patients.
Yeah, I think Lucy summed it up pretty much. But I have to say it is incredibly rewarding and satisfying. I think the medicine part is certainly challenging. I find that you do a lot more out of hospital care that would normally be done in hospital for patients that you would see in other settings, because it's harder to get a lot of the patients who are at risk of homelessness and who are homeless to go into hospital. And so you find that you definitely get your medicine tested, because you get to manage a lot more out of hospital, and obviously a lot of conditions that you have to manage as a GP, rather than quickly referring them on, because you've built the trust and they really want you involved in their care. I think it was interesting for me coming into it, because not like Lucy, I hadn't had decades of experience working in this space and had come from quite broad general practice, and then realizing I made a lot of assumptions about this population, and a lot of I think it's just sort of unconscious bias of which I think we were all guilty of thinking about what led to people ending up in this situation where they didn't have homes. And when you hear their stories, you do realize that it could be any one of us. And there's been a lot of challenges that these people have had to overcome, and they are beautiful, wonderful people to work with, and generally very keen on staying well. There was this assumption I had that they weren't going to be compliant, or they weren't going to listen to me, but it was quite a pleasant surprise to see how committed they were to work with you, how much they wanted to please you and do the right thing. And certainly is a very joyful place to work, because everybody's there who shares the same passion for wanting to make a difference and an impact to a population that is quite vulnerable and doesn't necessarily always get access to mainstream healthcare in the same way that people who have access to money and access to services. So yeah, I'd just say incredibly rewarding, challenging, but rewarding, and would certainly recommend people to look into it if they've got an interest.
Thank you very much. I might ask Jeanette, the women's health nurse, and Tally, who earlier presented on trauma, if they'd like to comment on the Cara case study.
Yeah, sure. I just wanted to just comment on study that I felt that there was a lot of trust gained, and particularly with the privacy and confidentiality that that Kira opened up quite a bit, because there was a lot that was brought up in that case study that was, and also covered in that in the consultation. I think it's really difficult when you're seeing a client for the first time to actually, and particularly as complex as Kira, ourselves, if there's a very complex case that I see in the women's health clinic, because we tend to focus very much on vulnerable and disadvantaged women, that you're already ticking off in your mind what you're going to be doing and where you might be heading in the consult. And I really try to keep in the moment as much as I can, because often you're sort of thinking about what where the consultation might be going, and just the comprehensive history can take some time. GPs do have time constraints within their consultations.
And I was going to add to that. I think the thing about Kira's history is, if you were to take it at the first point and miss the whole picture, that's what often happens in situations. So it's just they're presenting with one thing. And what actually happened was this unfolding of what was going on for the person. And I think often we miss the first signs of a traumatic past that people are experiencing, because we're looking at what the thing that they're presenting with. And I think because we looked at Kira's whole history, and because she felt safe, she was able to divulge that. Because often we think about a single incident when someone comes in with some sort of trauma, rather than the whole pattern of behaviour. And it showed that she'd had a history of trauma as a child, she'd had sexual assault, she'd had DV as an adult potentially as well. And so that's what we need to keep our eyes open for. And I loved that it was said that DV screening is an ongoing process throughout meeting with somebody, and just really trying to observe and understand the whole picture and the whole person. And I think that it very clearly did do that.
Thank you, Tali. We do have a question. How is education and training incorporated into the social life of these patients, so that they have at least some chance of being financially independent?
Well, in my experience, Paul, it's again comes down to engagement. I think for us anyway, towards the latter end of my career, I've found that more and more supports are wrapped around the men when they arrive, so that there is more hope that people become financially independent, have access to Department of Housing, reintegrate into the community, initially with support for their tenancy, but then, perhaps, for example, the hostel will have education around, which is available to everybody, around financial management. There are many educational programs that are run through an area adjacent to the hostel, but it's about hand in hand with other people, assisting people back into the community until they're ready to then be able to step out on their own, find a GP that they like, manage their own money. For some people that never happens, but for a great deal of people it really does.
Thanks, Dr. Cooper. Any other panel members want to comment on that?
I think
Sorry, go ahead, Tali.
Just want to think about the I guess one thing we need to understand is, what does the person want, what do they need, and how does that unfold for them? And so it's really just looking at where this person is and where they want to go with that. So I just want to be careful that we don't jump in with the whole picture of, well, we have to rescue them or fix them, and because that comes from a place that is disempowering and sets us up with power. So I agree with all the comments that Lucy mentioned earlier, but I just think we also need to be mindful of what we're asking and why we're asking those questions, because the system also works against people to actually be able to be so much more self-sufficient and re-traumatizes people. So that makes it quite difficult to move into a space where they can feel more empowered and able to do those things.
Yeah, thanks, Tali, for that great comment. I really like that question about looking at education and training, because it takes us out of looking at pathology, diagnosing problems, and maybe it's not so important to link that to financial independence, but it's probably important to link that to what gives meaning to a person's life and finding out how. In your presentation, Tally, I think we mentioned about day to day, what does the person do day to day? And for most of us, it's a mentally healthy thing if we have meaning to our day, and trying to establish what education training may contribute to a more meaningful day for folks is a really important component. And I really like that concept of moving away from the pathology and looking at strengths and what could strengthen that person's day. Got another question here. If the homeless patient is not contactable and there is a result which needs follow-up or referral to a specialist, should the police be involved to locate the patient to be able to discuss the result and to facilitate the necessary further investigations?
I might have a go at that one. I think there's been, over the 20 years, there was one episode where I did ask the police for help, and it was when I got an after-hours blood test result for somebody with a very high blood sugar, and I was worried they might go into DKA. I tried calling the patient's phone, and I thought they were at immediate risk of harm and illness. Generally speaking, I think, I'm not sure what Amandeep and others think, but I would probably gather as much history as I can at the initial point, like we did perhaps with Kira, about where the person might be staying, whether they have a phone. Often people who are experiencing homelessness have brokerage and have a phone. They might not answer it, of course. Friends, family, other contact people, but I wouldn't normally involve the police, no.
I might comment on that one as well. And it's one of the things that I see that's pretty wonderful about some of the homeless workers on the street. And it speaks to, again, one of the points that Tally raised, and that is that at a very early stage to seek consent. And many of the homeless workers do that almost as the first stage of talking to the person, because a key issue is that you do want to liaise with other agencies, and there's a reasonably high chance that the person will be lost to care at some point in time, or follow-up will not be perfect. And to a point I made earlier, particularly for people who are rough sleeping, they're generally known in Sydney. People do know where they are, and a service like Mission Beat will know the majority of people where they are, or they'll be able to link up with other agencies and find where they are. So it may be that the person's lost to care and there's a useful result that they should know about. If consent is sought at a very early stage, then I think you can start to link up, maybe not with the police, because that just seems like too much of a blue light type issue. Let's keep it sort of as a health issue to start with, and contact a service like Mission Beat if the person's rough sleeping. Or again, in that assessment stage, you should be asking who else is involved in your life in the non-government sector or in the health sector. Any other comments from the panel? Okay, well, thank you very much to those questions, and apologies if we didn't respond. The other things in the chat box were comments, and they were very useful comments, but I think we'll move on to the next stage of our presentations, and I'd like to introduce Jeanette Ball. Jeanette is a women's health nurse with priority populations at South East Sydney Local Health District. Over to you, Jeanette.
Sorry, Paul. I might just talk to this slide first before Jeanette talks about cervical screening tests. No, that's fine. So I just wanted to mention that there are digital health tools that are available to assist. So one of the things we talked about in the case study was just being able to gather information. I talked about how we didn't have a HPV vaccination record for Kira, and this is where the My Health record has certainly come into play in these sorts of situations where you're trying to gather as much information about patients who you may not have met before, or who may have interacted with the health system across lots of different health services. So you may find discharge summaries in the My Health record, pathology results, and certainly electronic scripts. And we talked about drug-seeking behaviour, prescriptions dispense and those medications that have been prescribed have been really handy. So getting that medication overview in the My Health record to know, did somebody fill a medication, a script for, endone that morning, and they're presenting to you for another prescription. So certainly been helpful in that regards. Obviously, there's imaging and pathology results, so you can make sure you're not duplicating tests if someone's already had something done recently at another practice or had something done at a hospital recently. So the My Health record certainly, if it's integrated into your clinical information system, can be really helpful. The other important digital health tool is a national cancer screening register. So we talked about Kira and trying to find out whether she'd had a CST before. So this is a service that can now be integrated into your clinical information system. So you can just have a sidebar access and be able to look directly up at somebody's screening records, results, and you can also update details if you need to, and just with one click can order kits if you want somebody to have a bowel screening, or you need to upload results or update anything in there. But that should all be sort of the truth in the NCSR, and you can certainly download some of those results to your clinical information system. So if you're not sure about whether you're connected, how you can get connected, certainly contact the digital health team at CESPN, because they'll be able to help walk you through that. And for people who have systems that aren't connected, you are able to go to provider portals. Again, the digital health team can help you with how you might be able to access those just through the web, even if you don't have that link with your best practice or medical director software. So I might stop there and hand over to Jeanette. I'm so sorry I stole your slide. Now your turn. Thank you.
Not a problem. Thanks, Amandeep. Thank you. I just wanted to do a HPV self-collection that became available in July last year. The National Cervical Screening Programme opened up self-collection of HPV vaginal samples as a choice to all people participating in cervical screening from the age of 25 to 74. And this is also a 5-yearly test. The self-collection allows screening participants to have the ability to take their own vaginal sample for HPV testing. And we know that people with a cervix and who participate in the National Cervical Screening Programme at this stage. So with the addition of the self-collection, we're hoping that there'll be an increasing number of participation, and possibly hoping for the elimination of cervical cancer in Australia by the 2030s. Certainly Australia is leading the way for this eradication, and if we remain on track, it'll be due to the screening, increased screening, and the HPV vaccination program in adolescents and young people. So about 70% of people diagnosed with invasive cervical cancer are underscreened or have never been screened. And for women, for most women, including those who may have a history of trauma, being able to offer a self-collect test may be able to address a significant barrier to participating in screening. Self-collection allows the patient a level of control and choice, and the self-collect test is for asymptomatic patients. Genital inspection can still be offered even if you are doing a self-collect test, and in particular in populations who are at risk or at high risk of vulvar disease. Self-collection is an option anytime a HPV test is needed, including for follow-up HPV testing after an intermediate risk result. The self-collection the 2% of people attending for screening have HPV 16 and 18 detected, and approximately 6% have a HPV other detected. So the rates of HPV 16 and 18 is very low. There is a less than 2% chance of an unsatisfactory result with the self-collect, and I think that's something that there has been concern over as well. And certainly an example of this, what I've experienced is mostly postmenopausal women that I see, and in my mental health patients. So using a topical vaginal estrogen prior to doing the self-collect or the clinician collected screening will return a satisfactory result at the next visit, and certainly abstaining obviously from the use of from the topical treatment 48 hours prior to the collection of the sample. Doing the self-collection, patients don't need to be observed doing the collection. Fact sheets which provide pictures in how to obtain the sample, and those fact sheets can actually be found on the websites that we've listed, which I'll go through as well. And if the person isn't comfortable or is having difficulty and not confident about collecting a vaginal sample, then you can assist by collecting the vaginal sample on their behalf without the use, obviously, of a speculum. Offering a patient a swab to do in their practice, swab tests could be used in the context of a telehealth consult if this is deemed appropriate by the clinician. Home collection in this instance may be a consideration for some clinicians. There's a range of collection devices and methods available to use under the National Cervical Screening Programme for self-collection. The self-collect swabs are available with several different pathology labs. So it's probably best to discuss with your usual pathology provider to samples, or if they're able to send on the self-collect vaginal samples to a lab that can process them for you. There are several Australian path labs accredited to process self-collect samples. There's the VCS Pathology, which is Victoria Cytology Services. VCS is actually the largest non-for-profit cervical screening lab nationally. They were the leaders in the self-collection. That's actually the pathology services that we use through There's also Douglas Hanley-Moyer Pathology and Sullivan Nicolaides Pathology in Queensland. Just as an aside, in terms of doing the self-collect, there is data just to, I suppose, support the efficacy of the self-collection. So the Medical Services Advisory Committee did an update in 2021 on the self-collect. We're able to show there was no diagnostic accuracy of HPV testing between self-collect and clinician collected samples, with a relative sensitivity of 0.98. With a 95% confidence interval of 0.96 to 1.01, and a relative specificity of 0.99, which 95% confidence interval of 0.98 to 1.01. So they concluded that the self-collect sample is just as accurate as using a clinician collected sample and is considered safe and effective. And just to add as well that the sensitivity and specificity of the HP and above in the self-collect samples were similar to those of the clinician collected samples using the validated PCR-based HPV assays. So if you do want to have some further information from the websites, the Cancer New South Wales government Cancer New South Wales government.au, gov.au, have resources in different languages, and also for the for Aboriginal and Torres Strait. So the cancercouncil.com.au provide a guide, a how-to guide for self-collection for health providers and clinicians. And there's also the health.gov.au website. Thank you.
Thanks so much, Jeanette. That was a really good update. So I'm just going to have a quick plug about HealthPathways. For those of you who are unfamiliar with HealthPathways, it's a website which is free to access. It's funded by your local health district to support primary care. We have some clinical management pathways and referral advice about your local health services. And it's designed to be used during your consult, so it's quick and simple. So I'd also like to make a special mention to Margot Woods, who's I think you're in the participants tonight, Margot, who's an experienced GP and clinical editor with Sydney Health Pathways, who we collaborated with to build the homeless health pathways and referral pages. Next slide, please. So this is the QR code for those of you who want to get the login. So that just links to the website, South East Sydney or Sydney Health Pathways. So this depends on which area of Sydney your patients are living in. So if they're in the sort of district where it belongs to Southeastern Sydney, you'd access that website, or if it's RPA, Concord, Canterbury, Balmain Hospital area, then it's Sydney Health Pathways, and that would give you local referral advice to those. If you don't have the login, just request it. You can use the feedback button on the page or contact Health Pathways to get the login. So there's a quick search area in terms of just basic overview of using Health Pathways. As you log in, there's a search bar at the top, and anything you type in, it will be indexed to certain sort of pages, topics, what we call Health Pathways. And then once you click on the pathway you want to see, you can do a quick search by using Control F as you normally would on any web browser. So you can expand on all those sort of collapsible items, or you can click and collapse as you go along. It's fairly self-explanatory. So using, as we said before, using South East Sydney version or Sydney Health Pathways will really depend on where your patient will be accessing the services. But that's an example of a page on your left there, so this is a hematology referral page, and we've actually listed both public options and private options there. And on the right-hand side there, it's very small font, but someone's highlighted at the bottom there. So depending on where your patient is going to be referred to, some specialized tests or, specific advice about investigations or management may be different depending on what the specialist service would like you to do. So for example, on this pathway about abnormal bleeding or bruising, they would like you to leave specialized tests ordering, such as von Willebrand's disease, to the specialist to request. So I think this is for Southeast Sydney. So this is the sort of host of pathways we've done in Southeast Sydney on homeless health. So we've got health assessment for people who are homeless. So have a look at these pages. They're very handy, and they've got lots of internal links to other pathways that you can sort of expand on, as Paul mentioned earlier. And there's housing assistance and homelessness, community food assistance, mental health support and assessment pages, drug and alcohol support and treatment pages, and Aboriginal Torres Strait Islander specific services, and a lot more other stuff in there like sexual health, mental health, and so forth. And then on this slide, we've got the pathways available on the Sydney Health Pathways website. So a fairly similar content, but definitely sort of localised and specialised for your local health district. So again, health assessment for people who are homeless, housing assistance and homelessness, community food assistance, adult mental health support assessment, financial counselling and support. So that's something unique that they have on the Sydney website, and vulnerable adult assessment. And then we've introduced this thing as part of Southeast Sydney recently. I think sometime last year or the year before, we've been launching this GP to GP referrals page. So we realised that a lot of us have a diverse range of skills and specialised knowledge, and it'd be great to share it with each other. So for example, some of you offer medical termination of pregnancy, Other people are interested in doing skin checks and skin excisions, and other people, do aviation health or trans health. So, and also iron infusions, etc. So unique services that you offer within your clinic. So if you're happy for your GP colleagues to refer you patients, then and you have a specialized skill set, at the moment we're looking for nominations in these areas in green, but I think there are more different GP to GP referral pathways we have worked on in the past as well. So if you'd like to add your name to any of these, you can use the send feedback button at the bottom right hand corner of the Health Pathways page after you log in, or you can email Sue Baker there with that email, sue.baker@health.nsw.gov.au. So we're always in the process of reviewing our pathways. Every 3 years, we have to ensure everything's up to date. So when the pathway is written and localized, it goes through a review process where so GPs working in the local area would draft it and then would communicate with relevant parties. So that would be all the stakeholders, specialists in your local health district and other NGOs and other organizations who are relevant to the pathway. And so when it comes back to 3 years, then it sort of, gets reviewed again. And it's a really good time for you guys to provide any feedback so we can update those pathways. And currently, as of this year, these are the pathways that we are reviewing. So diabetes, cardiology, rheumatology, immunology, infectious diseases, pregnancy, sexual health, and aged care. I think there's aged care is a big area we're developing at the moment. So if you have any feedback on those, we'd love to hear from you. And feel free to get in touch if you have any other feedback. So again, that feedback button at the bottom of the page, or you can directly contact the program managers, reviews managers, and project officers from your respective Southeast Sydney or Sydney Health Pathways teams. So, thank you, everyone.
Thanks, Karen. I just wanted to check if there's any last minute questions. We only have, I think, a couple of minutes. And if not, I just wanted to take the opportunity to thank all our presenters for sharing some really interesting case studies tonight and really thoughtful contributions. I've been asked to ask all attendees to remember to complete the evaluation that will come through. We've got some excellent and great comments coming through, so thank you everyone for that. And to finish the session, I just wanted to acknowledge that the primary healthcare services who provide care for people experiencing homelessness in Central and Eastern Sydney PHN, and these include the Exodus Foundation, the Haymarket Foundation, Matthew Talbot that you've heard a lot about tonight, the Kirkton Road Centre, Wayside Chapel Clinic, and the St Vincent's Hospital's Homelessness Health team. And without any further ado, I'd like to thank you all for attending and close this evening right on time. Thanks, everyone.